Okay, welcome everyone. I think Cheryl will just put you on mute for a minute, and Puneet. Okay, so welcome to today's webinar. It's a study evaluating access and care delivery of telehealth services based among community-based seniors. We'll follow the same format as normal and have a Q&A session after the presentation. If we don't get to all of your questions today, our presenters have offered to receive emails, and we'll put the emails up at the end of the presentation so you could email them directly. And please submit your questions online during the presentation, and as I said, we'll get to as many as possible. And at the end of the webinar, a survey will come up on your screen. And this is to provide feedback to both the presenters and to ourselves to improve the webinar going forward. And we will be putting up both the PowerPoints as well as the video in the next 24 to 48 hours. Just to quickly go over what are the upcoming webinars that we have scheduled so far. We have one Wednesday, October 25th, and that's A More to Eat by Heather Keller, and that was a SIG grant. On Wednesday, November 22nd, we'll be having Rick Sawatsky, and on Wednesday, December 6th, we have Exploring the Preferences of Older Canadians Living with Frailty for aspects of inpatient care. And if you go to our website, you will see all of our booked webinars, I think up to March. Maybe there's a few missing, but please register for those webinars if you can. For upcoming right now, we have a 2017 Catalyst Grant competition. It's addressing polypharmacy and related medication issues in older Canadians living with frailty. It is presented in collaboration with the New Brunswick Health Research Foundation and the Canadian Institute of Health Research. And the applications are for those who submitted an intent to apply, because that date has gone. They're due November 13th. And there's the website where you can get more information on this application. We do have another new funding opportunity, and it is just a recent funding opportunity that we've discussed based on the research patient priority setting process that just completed in September. You will see on our website that we've have the 10 priorities identified using the James Lind process, and we'll have a competition to address those 10 priorities. Details will be communicated further and likely in the next month or two, so please stay tuned. And I'd like to introduce the two presenters. I think Cheryl is going first. And Cheryl is Beryl and Richard Ivey Research Chair in Aging, Mental Health, Rehabilitation and Recovery at the Lawson Health Research Institute. Scientist and Assistant Director at Lawson Health Research Institute, and a distinguished university professor at the Arthur Labatt Family School of Nursing, Faculty of Health Sciences at Western University. We also, and I think Cheryl's coming from very far today to join us, so hopefully her presentation won't get at all cut off because of her distance today. But Puneet also will be presenting, and he's a practicing academic hospital in Ontario, and he teaches and supervises residents at both Western and McMaster universities as an associate clinical professor. He's the Chief Medical Officer of InputHealth Systems Incorporated. And Cheryl, we'll turn that over to you now.
Thank you. So I'm going to my slides now. So as mentioned, Puneet and I will be co-presenting, and we've mentioned the topic. You can see the agencies involved at the bottom here, and we actually have many more agencies and a much larger team. London Health Sciences and St. Joseph's was actually the site for the pilot that we'll be talking about. And this next slide just gives you a sense of the overall team. Although this was a pilot, we're planning for a larger project. So the representation includes people at other future sites that we would hope to include. And so that we're very much in the process of looking at how do we build on what we've learned in this process. And you can see at the bottom the wide range of people that were involved in this. So again, we're very thankful for the funding from the Canadian Frailty Network, because this was very important to us to attempt this pilot test. In terms of my own research, I do a lot of work around looking at health systems and innovations, as well as Puneet and Input is very much focused on innovations. I often say that you kind of live and die by the pilot project. We sometimes hear criticism about Canada being a country of pilot projects, but pilot projects are actually very important to work the bugs out in a small way before you go to a larger scale implementation. So in the title, you'll see this phrase TELEPROM-G, and what does that actually stand for? And so you can see the breakdown there around telemedicine and patient-reported outcome measurement, which is PROM, which is the platform. And in this case, the G stands for the geriatric population that we're working with. We currently also are just starting to work on the same thing, but with a Y for youth. So why are we doing this? Really, although we talk about frailty in many different ways, one of the really important things to consider is the impact of depression. And we know that's the leading cause of disability worldwide, and is a very important problem when we're talking about our seniors' problems. And you can see the statistics from 14% in 2010, and it's expected to almost double in the next few years. We have large numbers of seniors with these depressive symptoms living in the community, and it impacts on so many things in their life in terms of quality of life, risk of suicide. It also interacts with almost every other comorbidity and is considered our other problems, other chronic illnesses. Depression is generally a prognostic indicator, so it doesn't matter if you're talking about recovering from a fall, from diabetes, cardiac problems. For all these things, the existence of depression is very much a prognostic indicator. So it's important to address these issues. We think that mobile technology offers an opportunity to reach people in their homes, but that the actual research in this area is quite scarce. And this is, again, why we felt that the pilot piece would be very important. So with this, we just looked at 1 year to basically, our main question is, would this really work if we took it to a larger study? So you'll see, one, that idea of it, looking at the feasibility with this population, and then to determine, is there anything we would need to tweak or modifications before we scaled this up. So because it was a pilot, and although we had representation and members from multiple sites, we stuck to the London sites, which was St. Joseph's Hospital and London Health Science Centres, and 2 outpatient programs for people serving the older population, mental health outpatient programs. So to be enrolled, people had to be living in the community, and they had to have some depressive symptoms. They didn't have to have a full-blown depression, but have symptoms. And we also, because of the use of technology, we also wanted to look at some cognitive deficits where we would include people, but we didn't want people with less than 20 because of we felt that would interfere with their ability to use the technology. Not to say that there may not be other technologies where that would not be an issue. Okay. So this is what the population looked like. in terms of an older population, I'd say it's a younger older, like around 73. You can see that was roughly, well, exactly 60% female, 40 male. That the bulk of the population was living alone, be it widowed, divorced, separated, or single, never married, although 40% were living with someone in a married or common law relationship. Very much a spread around the educational level. As you can see, the highest proportion having completed high school, but fairly closely followed by some post-secondary. And although we did not require a diagnosis of depression, you can see many people, in fact, did have depression. But as you often see with mental health issues, there was a lot of comorbidities because almost 57% also had anxiety disorders. So what we did for this, the clients received a tablet device using an eHealth mobile software application. And this has the ability to track patient-reported health outcome measures and facilitate clinical evaluation. They also received the Wi-Fi for 6 months. Now, one of the really interesting things that we found, and we'll come back to this, we weren't really sure how many of these people would actually already have Wi-Fi, and we found that 20 to 30 already had it, and a few others had more of a like an internet base, but not necessarily Wi-Fi. So this is a huge learning for us going forward. In addition to, and Puneet's going to come into this and show you what it actually looked like shortly, but we also had the video conferencing functionality. Now, we had done a previous project using iPhones with people just generally from the general adult population. We had 400 people in that study. And one of the things we found is that our older population, there were some things about the other technology they didn't like that we were really trying to address. So for example, the tablet devices, people had talked about using a smartphone was a bit small for them. Small in terms of vision issues, but also small in terms of a lot of them had tremors or things that made inputting the data more difficult. And they also had said that they liked the idea of seeing and talking to their care provider, not just texting them. So very different than some of our other populations. So that's why this idea of the tablet device being larger and this idea of the video conference, so it could be a secure face-to-face, was really important and really based on the feedback we had earlier received. HCP stands for healthcare providers, so they receive training on how to use this, how to send the questionnaires, and how to conduct these virtual visits. So the questionnaires were sent to the clients by the healthcare providers. They were based on the client and site-specific requirements. So these were often things that people would be expected to fill out often at the beginning of the visit, but instead they would have that ahead and they could be doing these at different times, additional times. They were able to change the frequency of the questionnaires being sent and to monitor those results in real time. In terms of the actual design, we had a mixed methods approach because we wanted to look at both quantitative and qualitative measures because of wanting to use this to really plan for those next stages. And I'm going to pass on now to Puneet.
Great. I'm just going to show my screen at this stage. Thank you, Cheryl. Excellent. And now what you all should be seeing is a slide that talks a little bit about InputHealth. And again, briefly, I am the Chief Medical Officer of InputHealth Systems. We're a Canadian digital health company, and we've been the partners in this pilot with Cheryl and her team at Lawson, as well as with a few other projects within the space of mental health and patient engagement. So briefly about InputHealth, we were founded in 2011. We're led by a team of physicians, user experience designers, and technology entrepreneurs. Our headquarters is based in Vancouver, and we do also have offices in the Toronto, Hamilton area, as well as most recently now in Winnipeg and Kelowna. And our overall goal is to create really a much needed paradigm shift in the EMR market by introducing a platform that nascently allows for healthcare providers and patients to be able to collaborate and communicate through one system. So rather than, again, there being disparate systems and no communication through these avenues, we've really been trying to build a platform that can be leveraged to be able to accomplish that. And this really is the collaborative health record. We've been fortunate to receive a distinction for the efforts that we've been doing with the collaborative health record. We received an e-reporting of services award in 2014 from Canada Health Infoway, and through a number of other challenges. Most recently, actually, we also received the Social Venture Award at the New Ventures BC competition just a few weeks back. And aside from the exciting work that we've been doing at Lawson and at London Health Sciences and St. Joe's London, we're also proud to have had the opportunity to work with a number of other prestigious healthcare organizations, including the Mayo Clinic in the US, where we are the patient-reported outcome measurement platform of choice, with UBC and with several branches of the Canadian Mental Health Association. So in terms of what exactly the collaborative health record is, so the platform is an end-to-end patient engagement system with a powerful cloud-based health record system at the back end. So what this really means is that there's a broad spectrum of ways whereby patients and their healthcare providers can communicate through channels of electronic communication that we're already familiar with in society. So this could include receiving messaging, this could include secure email-based links that lead to educational material, that lead to the Q&As, which I'll be talking about shortly, which are our digital health questionnaires. And of course, the ability of being able to do virtual face-to-face visits, which has become an increasingly important part of the healthcare landscape. Most importantly with all of this is that the platform is designed in what we call a modular architecture. This allows the platform to be able to change with time. As we know how quickly consumer technology changes, we need to make sure that the technology is able to keep up with new methods of communication between patients and their healthcare teams. At the heart of the platform is the Q&A system. So Q&As are trademarked bidirectional information packages that allow for sharing of information with patients, with clients, and receipt of information from the healthcare team. An example could be some of these tools that we're seeing here, which I'll be showing you shortly, such as validated tools for the monitoring of mood, for the monitoring of anxiety, and so on. Most importantly, we also allow for organizations to be able to build their own tools or to leverage from existing tools, the some 300 odd that we already have built into the platform. So this allows for a very versatile but structured way to be able to see how people are doing and communicate meaningful information to them. So here's an example of an intro screen that you would see for one of the tools, in this case, the geriatric depression scale, which was used in the TELEPROM-G pilot. In this particular situation, this is being loaded onto a tablet screen, but these tools can actually be sent both remotely as well as to be completed on site. So remotely, they can be sent via an SMS-based secure link or an email-based secure link, such as what was used in the TELEPROM-G pilot. And on site, they can be loaded onto a kiosk or a tablet where data can be collected before patients interact with their healthcare teams, or even in some cases during those visits. So what the client or the patient sees, they see a very simplistic view of questions. This is, in this particular case, it's been intentionally made to be quite simple. This has been used in a variety of different clinical settings, and of course with various age groups, including the demographics that we discussed here in TELEPROM-G. And we found that patients have actually responded quite well to the interface, and this allows for easy response to questions. Currently, there's about 15 different response types or ways in which patients can interact with the tools. And in terms of what the provider or the healthcare practitioner sees on their end, they're able to see the data presented in a meaningful way, and they're able to see the aggregated score over time if it is a score tool. They're able to see trends and changes, and most importantly, we actually built the tools such that they convert the patient-reported data onto a natural language clinical note. And this has led to a tremendous amount of savings in documentation time. And some of the initial pilot work that we've done at the Mayo Clinic Department of Psychiatry, we've actually shown this can reduce documentation time by 65% because so much of the subjective history is automatically populated. And it can also reduce the length of the visits while still maintaining patient satisfaction, and while still having an opportunity for the clinician and their healthcare team to dive into other topics of discussion. Within the platform itself is, of course, also the capacity to be able to do virtual visits. This is something that's continuing to evolve. During the time of the TELEPROM-G pilot, our virtual visit capacity was restricted to the patient requiring a laptop or a desktop computer, or in this case, Chromebooks were used. But we've since then we've now enabled mobile-ready technology so that handheld devices can also be used to perform video visits securely. On top of that, we also have the ability to toggle an audio or video call, or just an audio call. So at this point, what I'm going to do is I'm going to switch my screen onto a live demonstration of the collaborative health platform. So just bear with me 1 second as I switch screens here. Perfect. And now what everyone should be seeing here is an image of the collaborative health record. And this is from the viewpoint of the healthcare provider. So the collaborative health record is a browser-based technology. In specific, it's a Chrome-based technology. So healthcare providers are able to log in through their distinct user accounts. The user accounts have the capacity to have an entirely customizable range of authorizations and permissions. So depending on the type of user, you can have a distinct set of permissions in terms of what you can or can't access within the platform. In addition, there actually is the capacity to be able to control access on a patient level as well. So certain patients, for example, may only be accessible by certain healthcare providers. So this really allows for that individual level of control of privacy and information. On the left-hand side, you see a variety of different tabs pertaining to the different functions within the platform. This is akin to what you would see in many modern health record or cloud-based health record systems. But what you'll also Q&Rs. And this is something that I'll focus on a little bit in the demonstration. So Q&Rs, again, being these tools that are custom loaded or custom built onto the account, allow for information gathering and information sharing. So in the case of the TELEPROM-G pilot, these are an example of some of the tools that have been utilized. So for example, some of the PHQ-9, which is a standardized tool for monitoring of mood, the GAD-7 for anxiety, and so on. In addition, some custom tools were used as well, such as a mood monitor, which was simply which was intended to be a way to simply assess for a person's overall mood at a given point in time. These tools, again, can be customized to look a certain way. They can be white labeled, and of course, they can be set to automatically go at the point of specific cues. For example, before a specific visit with their healthcare team, a patient can be sent a PHQ-9 and a GAD-7 prior to their visit, or it can be said that after the visit, every week or every 2 weeks, or however often it's felt that it's necessary, these tools can be sent off to the patients to be completed. So I'm sure you're wondering at this point, what does it actually look like to complete one of these tools? So I'll give an example. So I'll switch screens here to a demo screen of what it looks like when a patient receives a tool. So let's say, for example, we take a test patient, Jennifer Smith, and we select which clinician's inbox it goes into, and let's say we pick the PHQ-9. So at this point, when a patient receives a link, this is actually what they would see. It would say PHQ-9. It would show a brief description of the actual tool. All this can be customized, as well as a button to be able to start now. If it is a touchscreen device, they'd be able to complete this simply by touching the screen. And then the questions themselves begin. At this point, they respond to these questions. And again, as I mentioned previously, there are about 15 different response types. So the one that's being shown here is the single select, or the radio button response type. And what's also the other important aspect of what can be done with the Q&Rs is that you can build in a branching logic. So the PHQ-9 obviously doesn't have a branching logic in that everyone needs to complete all the questions, but the tools can be built such that depending on your responses, you can have an additional tool triggered. For example, if someone did say yes to a question regarding anxiety, a GAD-7 might be sent to them, or depending on the response, the person actually receives additional information as well. So I can demonstrate that to you. So in this case, this tool is done. They click on submit. The information is then sent to the platform. And now if I go back looking at the provider view on the collaborative health record, if I look at the inbox, what you'll actually see is that Jennifer Smith completed a PHQ-9 a few seconds ago. And this has also increased the number on the little red box here on the corner. And now when I click on the PHQ-9, I'm able to actually see the tool itself. I can open this to maximize the view. And what I'm able to see is actually a trend in the score over time. I'm able to see what the score itself was. It was a 14 out of 27. If I hover over previous dates, I can see on specific days what the score was coming back at. And I can also actually see the change in the trend of specific responses over time. So on a very quick color-coded basis, I can tell that Jennifer's been having more difficulty with her sleep, but her interest in activities has actually improved, and her energy levels have actually improved as well. At an individual question basis, I can also plot these and see, for example, how has Jennifer's ability to concentrate changed over time, and I'm able to see that individualized trend as well. So this is quite useful for point of care assessment of how a person is doing, and the beauty is that this can be done in an automated fashion, and it can be done in a way where the data is presented in a meaningful format. Now, the PHQ-9 is an example of a fairly simple structured tool. We can also build more sophisticated tools, such as, for example, what's called a patient intake profile tool, which is an intake questionnaire that can assess a far greater number of data points on how someone is doing. So here we'll demonstrate what it might look like when a patient completes some of these questions. In the interest of time, I won't actually go through the entire set of questions here. But you can see again that it can ask you, for example, who is completing this questionnaire. Now, in the case of the geriatric population, in many cases it might be a caregiver or another family member that might be completing the tool. You can specifically ask who's completing the tool, and then you can ask why specifically are you coming in, and then how your quality of life is doing. So this tool goes on. In this case, there's actually about 43 different questions in this particular tool, and what I'll show you is what the output of that is. So going back to Jennifer Smith's chart, I can actually look at her previous responses, and I can see that she'd completed a patient intake profile tool just yesterday. And looking at that, what I'm able to see is in this particular tool, there's multiple different embedded screeners. So there's a PHQ-9 screener within the tool, there's a GAD-7 screener within the tool, and I can look at all the different responses to Jennifer Smith's status. And if it's the first time that I'm meeting her, I now have a way of really getting a sense of how she's been doing. The impressive part is that we're able to convert all of the structured information, again, into a clinical note. So this is a summary that actually converts the patient-reported data points onto a clinical note, and this can be customized. So depending on the particular clinical user, whether it's a social worker, a family physician, a nurse, or a psychiatrist, they might want to present the information a little bit differently, and the output or the natural language conversion can be made different from provider to provider. And again, as I mentioned, we've demonstrated that this can save a significant amount of time from a provider perspective in terms of documentation. And one of the big things, obviously, in healthcare is that there's a lot of burnout relating to increased amount of administrative tasks relating to using traditional health technologies. And more importantly, this also means that the patient knows that this information is actually being reviewed and somebody's actually taking a look at this. One of the big fears that people have with regards to completing questionnaires is that you complete them and then you have no idea whether or not somebody's actually taking this into account, or you're being asked those same questions again. So this really allows you to alleviate those concerns. In terms of other patient engagement technologies, really briefly, within the platform is also the ability to do virtual visits. So we can do virtual visits simply by going into the patient's chart, clicking on Start Open, and sending what we call an ad hoc or point of care virtual visit, where an email can be sent to the patient and they receive a secure link to initiate a virtual visit. And you can also book virtual visits as a specific appointment. So in this case, for example, we're looking at the calendar. We see that there's multiple virtual visits booked, and these essentially would be able to send the patient a link as well. to begin the visit. The beauty of this is that you're actually able to engage in a virtual visit with the patient while you're still able to interact with their chart, make notes, review information about how they've been doing without having to leave the application. So it's all happening within one tool, and it's happening securely. There are other patient engagement technologies that are built into the platform that weren't utilized in TELEPROM-G, but may potentially be utilized in other studies that we do with Lawson. And these include the ability to be able to message the patient and the ability to be so directly, so you can get a secure message to the patient. And for example, in this case, you can send information on exercise and mood, so you can send vetted information to patients, and the ability to do e-booking. So there's much more that I can discuss here, but in the interest of time, I won't go into more detail at this point. I'm happy to answer any questions that people may have afterwards about the platform, but at this point, I'm going to hand things back over to Cheryl.
Okay, so, oops, sorry, that put me all the way back. Hold on. So going back to my screen here and looking at, so how would we evaluate this? And one of the things we found, we were doing a number of different technology evaluations, and we found that, first off, most of the technology is not being evaluated at all. But when it is, at best, it's looking at effectiveness. And I'm just seeing, I'm getting that little screen there. I'm going to just try to put that back on. So we think that certainly effectiveness, like does it work, is a very important consideration, but it's not the only consideration. What we also want to know about is what are the costs of doing this? How does the cost, which would include training, the cost of technology compared to usual care? We also consider that we have to look at policy and ethical analyses. So with the policy analyses, it's what kind of policies exist that would support the implementation of the technology or get in the way. And with the ethical analyses, we're looking at, is it actually the right thing to do? How does it stand up according to ethical principles, such as autonomy? Does it support patient autonomy, or is it getting in the way, making them feel dependent on the technology? What about privacy issues? How is this addressed? So we're doing different technologies at the Lawson. We're doing different age groups, different subpopulations, but we're trying to have this measure that looks at all four areas. And so for this particular study, we had one-to-one interviews because, again, it was a pilot study. These are the outcome measures that we were interested in with the idea of getting some idea of the change score so that we could know what an adequate sample size was. So we're looking at community integration, the depressive symptoms, use of services, quality of life, how their physical health was, and how they found the technology. We were really focused on process issues quite a bit in this study. So we had focus groups with both the clients as well as the healthcare providers. And we found that it was very positive. And again, when you think of the older population, you can see why some of these things would be particularly important. And one of the things that came up over and over, although they value the face-to-face in-person interactions with their care providers, and some of that could be home visit as well as driving in. With an outpatient clinic, a lot of it is driving in. And you can see that people felt not having to park, not having to deal with the weather, some of these people are coming from outside areas, that they felt it made the healthcare actually much more accessible if some of those could be a virtual visit rather than an in-person visit. They also found the technology very easy to use, and we were hoping that by having the technology, such as the tablets, they'd use it for other purposes. And they found that that worked very well, and particularly some of the links to other healthcare applications, as well as the general communication and keeping in contact. Some of the learnings we had were some of the interpretation of some of the questions on the questionnaires, which we've looked at. When we provided the Chromebooks to everyone in the initial study, because we weren't sure how many would actually have it, what we found is that people really tended to, the vast majority, I think it was 26 out of the 30, actually already had some sort of device, and they would prefer to use their own device so that they're not having to go between devices. So this also has huge implications going forward, because it's obviously cheaper to not have to provide devices. Our plan would be that we know some people are in impoverished situations and might be necessary to provide a device, but it's certainly not to the extent that we had originally thought. And with the changes, as Puneet mentioned, in the InputHealth application, it's much easier now to have a bring your own device. So that is certainly our plan going forward. The other thing was people wanted more. They found that sometimes the healthcare providers, in terms of the frequency and the consistency which they were sent, that they felt that they could have actually dealt with more. So again, the platform has been changed to address this, so that we can also have the client initiate things as well as the healthcare provider. So it's a good example of how the feedback from the groups was very quickly moved in to actual changes. And this was a 7-point scale that you're looking at now, and then you're looking at the responses. And so if you look at it in that way, 4 is neutral. And you can see the comments. A lot of them hover around the middle. The helpfulness, though, it was actually the most positive. And you can see some of the lower ones at the bottom end of the scale. So this gives us an idea of what we're doing well and what things we have to work on improving for the next go-round. In terms of the healthcare providers, they found it very helpful to have a more real-time evaluation of what's going on with their mental health status, particularly the moods, which can quite often vary even during the day. And so this gave them a much better real-time view of it. Sometimes clients will say, well, I'm always depressed, but when you can have that more fine-tuned thing and look at it during the day, it's quite helpful and really gives the healthcare providers much more direction. And again, the time constraints, given that this was a pilot and it was part of research, I felt it would be even more useful as part of practice, where it could be better implemented. There's always limitations when something is still within that research environment rather than the actual practice environment. And then again, it took the care providers sometimes some time in terms of the challenges with their own technology to learn that. We actually, based on the feedback for our next set going forward, we've changed the training module for the healthcare providers quite a bit to address the specific issues that they raised. So in terms of discussion, this was a pilot, but we found it worked quite well. And just in terms of the timing, we got the whole study in terms of getting the ethics approval, enrolling people, following for 6 months, and doing the analysis. We actually did the whole thing in 11.5 months. So within that, it was less than 2 months, more around 6 weeks to enroll those 30 people from the 2 sites, which in and of itself tells us a lot about the feasibility in terms of moving forward. We lost 4 clients during the 6-month period, which lets us know how many we need to recruit in terms of maintenance. But again, this was actually quite helpful, and we found most of them we lost within the first month or so, and it was generally related to comorbidities that they were finding difficult. So this has been very valuable insight for planning the larger study and giving us what kinds of enhanced communication do we need, what kind of technical support do we need, and what sort of training do we really need to do in the next phase. It certainly supported the idea of using technology to connect the older clients with their healthcare providers. Great deal of enthusiasm, as you can see, even in the recruitment, demonstrated that it could increase the communication and gave us those redesign ideas for moving forward. So our plan at this point, on that group at the very beginning, you saw we had people from multiple sites, including not only our London, but London in the UK. So our plans going forward is how can we now take this to the multiple sites. We have some references, which I'm not going to go through, but it will be available on the PowerPoint that will be on the site. And we're now moving to the question period.
Thank you, Cheryl and Punette, for sharing your work with us today. We don't often have the opportunity to provide a live demo, so we really appreciate it. It's very helpful in seeing what the whole context of it, and we'll set us up for our Q&A today. Today we'll have Perry Kim, our Manager of Research, who will facilitate today's Q&A. So, Perry, do you want to start the questions? I do hear a little bit of feedback, and I'm not sure where it's coming from. There we go.
Hi, everyone. It's Perry here. Thank you again for giving this talk. It's quite interesting. I encourage everyone that's listening to submit questions, and as we wait for these questions to come in, Cheryl, I was wondering, in terms of the pilot study, were there any surprises that you found versus what you sort of anticipated in terms of the results?
I would say our biggest surprise was the amount of technology and connectivity that people already had in their homes. When we originally set it up, we realized some people would certainly have their own computer, that they would have their own Wi-Fi already, but we didn't expect that high level, that in terms of the Wi-Fi alone, that 2/3 already had this. So this was very useful information for us, and I think we were surprised. I think for each study we've done with technology, the general comfort of our client population with technology each time re-impresses us and reaffirms the fact that this is really what our clients, our patients want, and it's something we need to be pursuing.
I got one question here. With respect to privacy issues, so maybe that's more directed to Puneet. Any privacy issues with respect to using cloud-based technology, Puneet?
Yeah, so that's a great question. And I mean, we've gone through privacy impact assessments and done a variety of different tests on that. So I think it's really something where we work closely with the organizations to make sure we not only comply with the necessary regulations, but exceed those. We really see the regulations as a baseline we need to follow. But as you can appreciate, it doesn't matter if you're the federal government or a bank or healthcare. Everyone is vulnerable to data breaches, as we all know. So I think we really need to push the boundaries with that and exceed those regulations and see them as a minimum baseline.
Mm-hmm.
Right, fair enough.
I would say it's important in healthcare for anyone, but for people with mental illness, because of stigma and discrimination, people tend to be particularly sensitive, and I think it's even more important. So I totally agree with Puneet. Like we see these different legislative and practice requirements as being the floor, not the ceiling.
Mm-hmm. Absolutely. In terms of client uptake versus healthcare practitioner up there, were there any surprises there? Did one group, I know you went through sort of at a granular level, but in terms of the group itself, did you find that the clients or the healthcare practitioners were amenable to using these services or these electronic services?
Well, both, Cheryl here, both were amenable, but I would say the client demand even exceeded the healthcare providers. We tried to have a range of people on teams, so some of the staff were more comfortable with technology than others. and so again, as I said, we've changed our training to make that easier. But what the clients were saying is they wanted more. They wanted more questionnaires, more frequent questionnaires, more contacts. And so again, we've changed the way it's set up a bit for going forward to allow that greater frequency. But it was really the clients, even more than the care providers, that were saying that they wanted more.
That's very clear. In terms of sort of on that line of thinking, what was the literacy levels of your pilot study population, and also in terms of their digital health literacy?
So we looked at there's a couple of measures. I don't have it right in front of me, but at one of the earlier slides, you would see the breakdown in terms of education. And so the majority had at least completed high school. We did have some that had only completed grade school. We had a questionnaire that looked, that we called it the perception of technology scale, that just talked about their general comfort with technology. And we found the vast majority were comfortable, but again, there was a range. There was a small percentage that felt less comfortable with technology. I think that worked out to around 4 or 5 people out of the 30 that were feeling a little bit less comfortable. So there was certainly a range, but that range was skewed to the higher comfort group. People were generally more comfortable. And again, this may be as a pilot, so this may be the group that's more likely to agree to participate in a study such as this. But we were taking them fairly randomly. We weren't narrowing down that selection.
Right, and I guess that's consistent with the fact that the majority had Wi-Fi already in their premises.
Yes. So 20 of the 30 had Wi-Fi, and there were a few others that had more a wire-based internet in the home. So they already, there was already that comfort with technology.
And can we assume that they all had internet service? Some had Wi-Fi and others did that?
No, yes, yeah, but there were a few that did not have anything in the home at all. Around, I can't remember, it's 5 or 6 people with nothing in the home. Some of those people were going down to the public library to access it there prior to the study, so it didn't mean that they weren't using it, but they didn't have it in the home. So not everyone had it in the home, but certainly the majority did.
And how did you deal with those individuals?
Well, we provided the Chromebooks and we provided the Wi-Fi in the home during the study period.
I see. So when you say Wi-Fi, are we talking cellular network connection?
We're talking about a wireless connection in the home. Puneet, you're the technological expert. Maybe you can better describe that.
Yeah, so my understanding is we basically had set up a Wi-Fi network connection within their homes. That was, I believe we'd use TechSavvy to actually be able to provide that.
Yeah.
Okay, so we have a couple of other research projects on the go here, and the Wi-Fi is connected to the cell network. So I think probably that sounds like what was happening there. In terms of the clients, curious, I'm not sure if you addressed this, but were they predominantly urban, or was there a mixture of urban and rural clients?
There was a mixture. A large number of them would come from the London area. So the people that were enrolled through London Health Science Centre are more within London Middlesex. So London is surrounded by a rural area, and certainly the catchment area at St. Joseph's, Parkwood Institute Mental Health, has an even wider geographic area. So in this case, some people were really coming from a much further distance to come in for the visits. But even at London, like Middlesex County, it is primarily rural area. London is in some ways an ideal place to study because it has that urban population, but you have to go out about 100 kilometers to find another center that has 100,000 people.
Mm-hmm.
So you get that urban-rural mix.
I'm just going to read one question here. What barriers, etc., would you anticipate within institutions/systems in developing and implementing the use of such an amazing, innovative, and comprehensive communication technology.
What was the very first part? What would we anticipate? Oh, barriers. Okay. Panay, did you want me to take this, or did you want to take it?
Yeah, maybe do you want to take the first part, and then I can add if there's anything else.
Okay. So I would. There's several pieces to it. It involves the procurement, the hardware policies at the individual institution. It involves the training that the staff needs to have to take. But I think on a larger level, it involves the vision of the leadership, and to move forward to this. I think if people are, in terms of their vision, are looking forward, what is the future of healthcare, this becomes very obvious and very attractive. If people are more focused on how things have usually gone in the past, then it's going to be more difficult. We find it's really important to engage the IT department from the onset, to engage with the privacy and security department so that they can be part of the conversation. They're a really important part of the team with these issues going forward. I think they appreciate that we're not just looking at the effectiveness on the client, but we are looking at some of these broader issues, such as the ethical dimensions, the privacy dimensions, and how it fits with the policies and the technology at the hospital. I think those things really need to be up front and on the table, and we need to be considering these people part of the team and how we go forward. And Puneet, what am I forgetting?
Sure, I can add a couple of points. So one of the things I can say, kind of, especially as a smaller vendor, and I can say a lot of innovation does come from the small and medium-sized companies in the space. The traditional procurement process, I would say, is probably in and of itself a barrier with regards to being able to bring in innovation. So I think that's one thing that's I'd say it's an ongoing problem. I think it's being recognized as a problem, and there are kind of new practices or co-design and innovation procurement practices that are improving the process, but otherwise the actual requirements for a lot of those procurement exercises actually preclude the participation of small and medium-sized organizations. The other thing I would say is the experiences we've had in other institutions as well, be it UBC or Mayo Clinic, was that there was huge value add brought when you actually engaged all stakeholders, not just, I guess, quote unquote, classic stakeholders. Classic stakeholders being, the physicians, senior administration, and then patients. Of course, those are of importance, but you really have to think about all other providers that are in contact with the process. An example would be support staff and front desk staff, reception staff, appointment booking staff. They often are never really sold on the value of these technologies, and they, in many cases, use it more than anyone else. So I think that really having all the different stakeholders understand the value of what you're doing and ensuring that there is a value add for everyone is important in successful technology.
Just sort of related to that last point, Nate, I have a question here in terms of the incentives for physicians and other healthcare professionals. How are they remunerated for the online interactions? Is it similar to the visit, regardless of whether it's online or in person and so forth?
So you cut out there for a second. Could you repeat the last part of the question again?
Absolutely. So it's related to how healthcare professionals and physicians are paid for their online interactions with their patients versus, I guess, actual in-office visits, and whether there's less or more incentive, or is it exactly the same as far as you're aware?
Yeah, so great question, and I think that's an evolving area as well. It varies from province to province. In Ontario right now, there isn't a lot of funding around virtual care delivery. So some physicians who may be salaried or who might be part of alternate funding models may be able to provide this type of care, but those in the overarching group of fee-for-service don't have too many codes available. There are some, but they're very restricted, and they're for very specific types of clinical interactions, often really between a provider and a provider. In other provinces, actually, I think in BC, as recently as within the last 48 hours, they released a variety of new codes and funding models for being able to provide electronic care. So I think there is an evolution happening. Different provinces are at different stages, I'd say.
Yeah, I'd like to add to that. I think Cheryl here, it speaks to the importance of including the policy analysis. And even with the 2 hospitals we had participating in the study at St. Joseph's, the Parkwood Mental Health, the physicians there would be on salary versus a fee-for-service environment in the more acute care hospital. But in both, we were looking at the outpatient clinics where there's a variety of healthcare providers involved, and the majority of those healthcare providers are salaried. So the issue is not, it really boils down to the difference when you end up with a fee-for-service environment versus a salaried, and it's certainly one of the things that we are looking at going forward. But as Puneet said, this is a rapidly changing field in terms of what's acceptable. Even a few years ago, people may remember when there was much more restrictions even on telephone contact. So I think these things are catching up in terms of what needs to happen from a policy perspective.
Thanks, Cheryl. And yeah, I think there is a lot of work to be done in this area. And I think many of our projects are coming across this as well. And so I think there'll be a lot of development across Canada in the next little while. I think we've come to the end of our Q&A session. And Cheryl and Puneet, do you have any final thoughts to share with us before we end today's webinar?
Well, just thanking you for the opportunity, and thanking you as well for the funding, because I think this is a new emerging area that we're all going to be seeing so much more of in the future. And also thanking our partners at InputHealth for being so flexible to come up with what the end users really want.
Absolutely, I'd echo the same. A great thanks to CFN. This has been a great opportunity. We really see this as the beginning. It's been a pleasure working with everyone at Lawson, London Health Sciences, St. Joe's, and thank you to everyone for listening in today as well.
Oh, great, thank you. And I see you both have offered, and on the screen you'll see both of the emails. There are a few questions that we haven't been able to get to today, so feel free to either contact Cheryl or Puneet. And then you'll see that our next webinar is October 25th with Heather Keller. So I'm hoping you'll join us at the next webinar. And I'm thanking everybody today for the great discussion and questions, and hope everyone has a great rest of the day. So goodbye, and hope to see you on October 25th.